That's a good segue to our next point, which is the newer therapies for the lower risk patients. I think there are some exciting developments in this area. I mean, you want to talk about what's coming up and what we can expect in the next few years.
Sure.
Luspatercept.
Right. Yeah, I think you know the first thing that is jumping really now at this point is the TGF-beta inhibitors. So I think you know what's changing obviously is our understanding for the disease. What we've made in the last 5 years, while we did not have a drug approved in MDS, is we learned a lot about the biology of the disease. And I think we look at the disease now in almost like phases. You have a pre-MDS phase where you have some of those, you know, somatic mutations at low level and inflammation going on, innate immunity affected. The first part of the disease really seems to be there is inflammation that sets this genetic instability. And at one point, the disease gets clonal, and it's really clonal evolution after that. So that window where the disease is inflammatory, let's say, or the inflammation is a major contribution, people are starting to look at new agents. And that has been exciting because we've never had, other than the traditional cytotoxic therapy, looked at in this setting. So one of the things that started first is looking at this TGF-beta inhibitors. So it turned out that this pathway is overexpressed in MDS patients, and it contributes to myelosuppression. There are downstream proteins that are, you know, upregulated, and there are drugs that were originally used for targeting the TGF-beta to improve osteoporosis, sotatercept. The toxicity in healthy volunteers observed was erythrocytosis. It turns that those drugs work on terminal erythroid differentiation, improving erythroid production, and there had been some studies in cancer-related anemia, renal anemia, thalassemia that are promising. So 2 agents have been tested in MDS. We tested the sotatercept. Our German colleagues tested luspatercept. Both of them demonstrated a good signal of response, particularly if the patients were not heavily transfusion dependent. But then there was that signal that basically maybe the patients with ring sideroblast have a very high responses, ranging in 60 to 80% of the cases. So now the luspatercept have been moved forward. It's one of the few studies that are in phase 3 in MDS as a registration study, where patients with ring sideroblasts, subtypes, lower risk, after ESA failure, they are randomized to luspatercept versus best supportive care. And if that study is positive, I think this will be hopefully a drug that will get approved in MDS. So the TGF-beta inhibitors are interesting. There are some that those medications are fusion trap proteins, so they bind the ligands before binding the receptor. But there are also some tyrosine kinase inhibitors that are looked at the same pathway, so those are in development. And then that theme of targeting inflammation, we heard at this meeting very early data on phase 1 with the toll-like receptor 2 monoclonal antibodies. So in a phase 1 study, there were responses seen, hematological improvements, which is interesting. We are looking at neutralizing also trap protein for a protein called S109. So we are targeting the inflammation in the early phase, and I think that's a promising thing. When the disease becomes more clonal, I think we are starting to look at those mutations and can we target those. So as in the ring sideroblast, since we were talking about those are very highly enriched in splicing mutations. We are seeing now the first in human studies with splicing inhibitors in patients with MDS. So that's very exciting. Those are, you know, disease-initiating events that if you could eradicate the clone, you make an impact. We heard at this meeting about, you know, IDH2 mutation, which again,
a small subset.
Exactly,
right.
5 to 10% of the patients, but it seems that there are responses, whether it's like eradication of the clone or differentiation. One of the things that also is like emerging as a difficult to treat or challenging is the P53. Those patients that have P53 mutation, typically this is seen in higher risk, complex setting, but there is even subset with D5Q that they have that mutation. They do respond upfront nicely to any therapy like others, but the duration of response is very short-lived, and the survival for those patients, unfortunately, is less than a year. So there are like agents going in clinical trials trying to modulate or target the P53 mutation. So, you know, there are several things. I think in early MDS, inflammasome, in later MDS targeting mutations. I think we heard a little bit about checkpoint inhibitors in MDS, which is again a modality that's been tested in every disease. It's too early to tell where are we going. I think we know some safety, but we are still far away from assessing efficacy.
Yeah. I think it's a very exciting times in the MDS field after many years of having no real therapies with clinically significant benefit. Now we are seeing all these agents. I just want to stress the fact that these the importance of enrolling these patients on clinical trials, because these are low-risk patients. They may be, some of them may not even need any treatment for a long time, but I think they will have the option of going into these trials if they are referred to appropriate centers. So I just want to stress that.
Even just registry study, for example, the large efforts now to try to have majority of the patients registered in national or local registry, and that's really important to learn about the pathophysiology of the disease, especially in the early events.
And to put rather than putting a low-risk patient on a hypomethylating agent, there are, for the first time a lot of choices. You know, there's the phase 3 of the luspatercept trial. Which
I think we just have to make sure the patients have access to these newer therapies. So I think that I just want to make the point that all these patients would benefit from referral to specialized centers.
To that point, I think Thomas published a paper on JCO looking at the outcome of patients after HMA failure, and actually the best outcome for patients were either if they went to transplant or they were enrolled on clinical trials. So we do help the patients by enrolling them on clinical trials, you know, and whether it's just because of more monitoring and being on top of things or the ages, but you know, those patients benefit from enrollment in clinical trials.
And we don't learn otherwise unless we can enroll patients on clinical trials, so that our ability to move forward and move this field forward to more therapies that actually are successful depends on us being able to enroll patients on trials.
And I think it's also important to stress that for the moment, all the therapies that we have, with one notable exception, are disease-controlling therapy, but not disease-eradicating therapy. The only exception, which is unfortunately not available for all the patients, is allogeneic transplantation. And so that's also something that needs to be stressed. We need to refer the patient to a specialized center for a good assessment of the disease, from the diagnosis to what kind of therapy we can see. But there's also the question of transplant.